Good evening, everybody. And it's my honor and pleasure to have all of you here today on the eve of World Sickle Cell Day. As we all know, sickle cell was always important, but now getting more important thanks to advocacy of all the groups, medical groups, as well as all NGOs and patient groups who have started working together to bring more awareness. I am really very happy that we have been represented by a large panel today who would discuss about sickle cell disease. And as you all of you know, that government of India is likely to launch a big sickle cell mission next week on 27th from Madhya Pradesh. A sickle cell mission means the programs which are already running, they will get more focus, more funding, and there will be more awareness. Naturally, as we know, most important in sickle cell is an awareness. Unfortunately, fortunately, in last 6 months, I have done a special campaign on sickle cell disease, and I have been able to clinically examine beyond 1,500 patients in various parts of India and Africa. And what I realized that despite treatment available, despite facilities being free, despite facilities being accessible, the morbidity of the disease is really very, very big. Patients are suffering, their quality of life is not good. So morbidity always remains a challenge in sickle cell disease. That means whatever treatment is available today is not enough to offer them good quality of life. So our research into sickle cell, our cooperation into sickle cell has to continue. A lot of new things are coming up. Bone marrow transplant is available, is becoming more popular. Gene therapy is likely to come in. Uh, Gene editing is coming in. So things are happening, but unless we continue our advocacy, we will not reach our targets fast. So our advocacy of all of us is important. Today with us, we have a very prominent personality on sickle cell disease from University of Chicago, Professor Santosh Saraf, who is Associate Professor of Medicine at Division of Hematology in University of Chicago. And he is available today, works on multiple aspects of sickle cell disease, right from genetics to clinical. It's really honor and pleasure to have him. He is a world-renowned expert on sickle cell disease, and I personally feel all of us today will benefit from his interaction about sickle cell disease. I have met him last week in Chicago. He gave me 4 hours of research into sickle cell. No American professor does that. So I'm extremely obliged to him, and we are honored to have him. And I'm sure his cooperation with us really make us strong, all of us together as a society. Over to you, Dr. Santosh, please.
Thank you very much for that kind introduction. And it's a great pleasure to collaborate with you and everybody here. I'm very excited about the opportunity to learn more about sickle cell disease, both hear how it compares in Chicago, but also how it impacts people in India. So over the next 30 minutes, I wanted to give an overview on updates on the morbidity and therapies for sickle cell disease. And my email is listed here if anybody ever wants to reach out for any questions. So as we all know, sickle cell disease really is a global disease. About 300,000 births per year are affected by sickle cell disease, and it's estimated 25 million people have the sickle cell SS mutation. When you look at the distribution of hemoglobin S, there are dense pockets of it located in Western and Central Africa, in the Mediterranean region, Middle East, and in India. And it overlaps where just the malaria is prevalent. And that's because there's a survival benefit of having the hemoglobin S mutation against more lethal malaria infection. There are some common genotypes that we encounter, and they're due to either homozygous or compound heterozygous mutation with other mutations. So the S mutation is the glutamic acid to valine substitution. If you inherit 2 beta globin genes affected by that, you have a severe anemia, high levels of hemolysis, you're going to often see both hemolytic and vaso-occlusive complications. Another common genotype, we see it in about a quarter of our patients, is a compound heterozygous mutation of the S mutation with C. This is a glutamic acid to lysine mutation. This leads to a little bit more of a moderate anemia, mostly vaso-occlusive problems, less of the hemolytic type complications. Then you can also co-inherit hemoglobin S mutation with beta thalassemia. If you have complete zero thalassemia without expression, then this phenotype is very similar to SS. If you have partial expression of the beta globin gene, you will have some hemoglobin A present, and this makes the phenotype a little bit milder, mirroring more the SC genotype. And this should not be confused with sickle cell trait. The key here is the ratio of S to A. If there's more hemoglobin S than A, it's sickle cell beta plus thalassemia. If there's more A to S, that is sickle cell trait. The consequence is that when that hemoglobin S or C gives off the oxygen, this leads to polymerization and sickling of the red cell. This causes vaso-occlusion, hemolysis, and anemia. And the red cells course throughout the whole body. So from head to toe, no organ system is spared. Every organ system is impacted by sickle cell disease. So there are some initiatives that have helped, particularly children. That includes newborn screening. This is critical because knowing which patients have or which babies have sickle cell disease can then lead to penicillin prophylaxis, which reduces pneumococcal sepsis, especially during the first 5 years of life. Early initiation of hydroxyurea appears to be protective. And then transcranial Dopplers, if you have a high Doppler velocity, that means that you have a narrowing of the intracranial vessels. And those children put on transfusion protocols have over a 90% protection from stroke. And with these types of initiatives, the majority of children can survive into adulthood if you can initiate these. This is shown here in the CDC, where you see mortality rates improved by decade. However, mortality remains very high, still in this 20 to 50-year age group. Many different longitudinal cohorts have looked at predictors of mortality, and we're going to come back to this table because this is going to guide for when we should think about therapies. But many different acute complications, like the frequent vaso-occlusive crises, acute chest syndrome, and stroke, have been predictors of early mortality. But other things that are also emerging include cardiopulmonary disease and kidney disease. And these are all many different cohorts over a span of about 30 to 40 years. So what is causing the mortality? And here's a study from a cohort in Jamaica that looked at younger children that were passing away. And most of these were acute complications like splenic sequestration, sepsis, stroke. What was driving mortality in the older age group was more the chronic organ damage, things like heart failure and chronic renal failure. And what we're learning is that as our patients are surviving into adulthood, heart, lung, and kidney disease accounts for the majority of identifiable causes of death. Cardiovascular disease accounts for about a quarter of those deaths. And one of the biomarkers that we use is a high TR jet velocity that you can measure on a transthoracic echocardiogram. A reduced FEV1, it might be a consequence of recurrent acute chest syndrome, but also from pulmonary damage from the sickle cell disease predicts mortality. And then reduced kidney function, an eGFR less than 90, which we often think as normal, that is associated with a threefold higher risk of death. So all of these chronic organ systems are very vital for the body, but are also damaged as our patients age. So when people have tried to understand what's driving this damage, what we've noticed is that there seem to be two broad phenotypes. There's the hemolysis phenotype and the vaso-occlusion or viscosity phenotype. And patients often kind of overlap in these phenotypes. So these aren't clean phenotypes, but we start to see this kind of spectrum when we look at kind of a population base. So with viscosity or vaso-occlusion, that's where the blood flow is interrupted and you have downstream ischemia. And this is associated with the frequency of pain crises, acute chest syndrome, and avascular necrosis or osteonecrosis. On the other side is hemolysis, and when the red cell lyses, this releases toxic cell-free hemoglobin and heme, and this leads to both vascular damage, but also organ damage. And so what we tend to see is that people that have a lot of hemolysis tend to have these kind of chronic organ damages like pulmonary hypertension, kidney disease, leg ulceration, priapism, and stroke fall under this category too. So when we talk about sickle cell disease, it's a beta globin mutation, but the phenotype varies. And so why do these patients have these different kinds of phenotypes isn't very well understood. But I think genetics might help us understand some of this, this difference. One of those mutations is in alpha thalassemia. So if you co-inherit alpha thalassemia, and this can be either a single or double deletion. So normally we have 4 alpha genes. So if 1 or 2 is missing, which is seen in about a third of our patients with sickle cell disease, this lowers the density of the red cells. And this is actually protective. So those that have less red cell density have less hemolytic anemia. So if you have less hemolysis, this might protect you from some of those hemolysis phenotypes like kidney disease, leg ulcers, and cardiopulmonary disease has been observed in the literature. But it does not seem to be protective from vaso-occlusive crisis. The other common variation involves higher hemoglobin F. And this is because the gamma globin gene isn't turned off at about 6 months. This can be due to hereditary persistence of fetal hemoglobin. Certain haplotypes differ by their fetal hemoglobin. But one of the targets of gene therapy is this gene BCL11A. This is a promoter, this is a transcription factor that binds to the promoter region of gamma globin. And normally around 6 months, it turns off gamma globin. But if there's this mutation, that turning off is ineffective. And so patients have higher fetal hemoglobin. And so in gene therapy, what they're doing is they're introducing this actual mutation and then giving those stem cells back. And that leads to higher fetal hemoglobin. And many cohorts, the cooperative study of sickle cell disease demonstrated that a higher fetal hemoglobin reduces vaso-occlusion and mortality. Threshold of more than 10% is associated with less stroke and avascular necrosis, and over 20%, which is often what we try to aim for with things like hydroxyurea, reduces vaso-occlusive crises. So to summarize part 1, sickle cell disease causes substantial morbidity and early mortality. The genotype, alpha thalassemia, and BCL11A influence severity. Childhood mortality can be improved with newborn screening, penicillin prophylaxis, and red cell transfusions, especially if you have an elevated transcranial Doppler velocity. But adult mortality remains high, and this is due to both acute and chronic organ damage, particularly to the heart, lung, and kidneys. So let's shift gears to the therapy. And hydroxyurea is one of our tried and true medications. This has been around for several decades. And one of the main studies that showed that was the multi-center study of hydroxyurea. This is where 300 patients with frequent crises were randomized either to receive hydroxyurea or placebo. And here the dose was titrated out. So here they aimed for myelosuppression, which often comes with the burden of monitoring CBCs and being careful about bleeding or infection risk. But with this approach, crises, acute chest syndrome, and transfusions were all significantly improved. There have been studies both in India and in Nigeria looking at fixed dose hydroxyurea. This is 10 milligrams per kilogram per day. And in India, it was shown in children, those with complications had a significant improvement in vaso-occlusive crises, improvement in hemoglobin, and a reduction in transfusions. While in Nigeria, in a smaller cohort, it was shown that even this low dose has substantial improvement in fetal hemoglobin or hemoglobin F. Some of the other therapies that have emerged over the past 5 years, one is L-glutamine. This is actually an amino acid. It's a powder that you mix in a beverage twice a day, but it's essential for NAD production. And so NAD is part of the antioxidant system. And so if you improve this antioxidant, we have in vitro less endothelial adhesion. In patients where they studied this, it was shown that L-glutamine reduced the vaso-occlusive crises down from 4 per year down to 3 per year. So this was approved about 6 years ago. We do see some modest improvement in some patients. Because it's a beverage, we do get some GI toxicity. So we warn our patients about that. And if they're having that, I reduce it down to once a day. The other mechanism is that for the occlusion, these white cells and red cells interact, and to bind to the endothelium, they need these anchors called pre-selectin. So antibodies have been developed to kind of break this anchor and try to inhibit that adhesion. So the one that was approved was crizanlizumab. This is an IV infusion given every 4 weeks. And in a study of 200 patients that were randomized either to placebo, a low dose, or high dose for a year, it was shown that the intermediate dose reduced crises. The actual approved dose, 5 milligrams per kilogram, led to a 50% reduction in vaso-occlusive crises, as well as time to first vaso-occlusive crisis. So in summary, FDA-approved therapies to reduce vaso-occlusion include hydroxyurea, L-glutamine, and crizanlizumab. Now, there is one other class of medications that goes and tries to inhibit the polymerization. And so if you remember, when the hemoglobin gives off oxygen, this causes this to polymerize in the red cell to sickle. So a medication called voxelotor was developed that binds to the alpha-globin gene, and it helps keep that oxygen bound to the hemoglobin, thereby inhibiting the polymerization. And in a study of 274 patients randomized to placebo, an intermediate dose or a high dose of voxelotor, at 24 weeks, those patients that received the high dose of voxelotor were all on this positive end of the waterfall plot, having an improvement in hemoglobin. Intermediate dose had a modest improvement. Placebo, as we expected, had kind of a mix of some going higher and some going lower in their hemoglobin. The delta in hemoglobin concentration was 1.1 grams. About 40% had a 1.5 gram improvement. And so this might target more of that hemolytic phenotype, while medications like hydroxyurea, crizanlizumab, and L-glutamine may help more with the vaso-occlusive phenotype. So coming back to our predictors of mortality. So a lot of these predictors have been observed still in the era of hydroxyurea. So we know that hydroxyurea helps, probably these other medicines also help, but patients still can have complications despite this. And these complications, because they're consistent predictors of mortality, also have been considered indications for transplant. And so different societies have come up with when to consider patients for transplant. All of these are in the setting of having tried hydroxyurea or having had intolerance to it. But people that have a lot of these complications, stroke, pulmonary disease, vaso-occlusive crises, kidney disease, pulmonary hypertension, these indications when we start considering a patient for HLA transplant, HLA-matched transplant, especially if they have these despite hydroxyurea. Alternative donor transplant with unrelated or haploidentical transplant has also gained popularity as our regimens have become safer and more effective. And here the criteria have been primarily stroke, pulmonary hypertension, current episodes of acute chest syndrome or vaso-occlusive crises despite these disease-modifying therapies. But we often think about the complications, but I think it's also important to understand what the patient believes. So what are the acceptable risks of a transplant that the patient is willing to accept? And 2 different studies have tried to look at this. What was surprising was that there was no association between what kind of risk you would accept versus how severe your sickle cell disease was, which is a little bit of a surprise. But what they looked at was that about 10% of patients in both cohorts, about 50 to 60% of patients in both cohorts were willing to accept a 10% mortality risk. And as I'll show in some later slides, we are at that 10% or better. 20% were willing to accept a risk of chronic graft versus host disease. That has also improved. And then fertility issues have also come up. So that's another important thing to bring up with your patients. And as we reduce the intensity of those regimens, we're seeing less and less fertility problems. So over 2,000 patients have been transplanted worldwide for sickle cell disease. And here's a summary of the results when you use an HLA-matched related donor. So with myeloablative approaches, it does carry more of a risk of graft versus host disease. However, stable engraftment is very high at 91%. While if we scale back the intensity of the regimen using non-myeloablative approaches, we get less of a risk of graft versus host disease, but stable engraftment also gets compromised. So this is coming from a large analysis of over 2 decades in 2019. I'm going to show you some data showing that we've actually been able to improve the stable engraftment using alternative non-myeloablative approaches. The other caveat with myeloablative approaches is age. And so younger patients can tolerate a myeloablative approach better. However, once you hit an age of 10 to 15, that's when the risk of graft versus host disease, mortality, and graft failure start to rise. And so now you have to start worrying about the risks-benefit ratio based on what type of myeloablative versus non-myeloablative approach that you'd like to try. So here is some data from our center, the NIH, and from Saudi Arabia, looking at a non-myeloablative, we call it a chemotherapy-free approach. And here we use alemtuzumab given for 5 days. So we start off with an exchange transfusion. And we give alemtuzumab over 5 days, 1 dose of total body irradiation. We start sirolimus, and then the stem cells are infused through a peripheral line. And in this cohort of 122 patients, our median age was almost 30 years old. It spanned from 10 to 65 years old. Most were SS, most were on hydroxyurea. We observed stable engraftment in 87% of patients. Remarkably, no patients have had chronic graft versus host disease. Here are our chimerisms. And so you do get a mixed chimerisms because it's non-myeloablative. But for myeloid chimerisms, you only need about 25% stable donor engraftment to reverse sickle cell disease. Well, to come off of sirolimus, we've set our CD3 or lymphoid chimerism at 50%. What you can see here is by about 2 to 3 years, the majority of our patients, 3/4 are off sirolimus. By 5 years, 83%. Unfortunately, a lot of our patients don't have age-linked matched siblings. So when we look here, and we already have a little bit of a referral bias because usually people that have siblings are referred to us, but about 20% or less of patients that are evaluated have a age-linked matched sibling donor. And so people have looked at other approaches, and haploidentical approaches have really gained a lot of popularity, thanks in part to the approaches from Johns Hopkins, where they give post-stem cell infusion cyclophosphamide. This is given at 50 milligrams per kilogram, and the stem cells have aldehyde dehydrogenase, so they're not affected by cyclophosphamide. While the active lymphocytes the alloreactive lymphocytes that are trying to initiate graft versus host disease or rejection, they are activated during this period. Cyclophosphamide is very effective at turning those off. In a very nice meta-analysis of about 150 patients that received this approach, the rates of graft versus host disease were low, 4 and 11%. Stable engraftment was 93%. And this is very comparable to the data from Dr. Epen looking at age-linked matched siblings. So I think that we are getting closer and closer to having a really nice haploidentical approach. People have had some differences. Some add thiotepa, some use a higher dose of irradiation, and that can be center specific. But in our experience, we don't use thiotepa. We give 3 graves at TBI, and out of 21 patients, 90% have had stable engraftment. We have had 3 with chronic graft versus host disease, and so compliance with sirolimus is critical, and that was one of our patients. The other 2 had improvement with the dose of steroids, and one is on ruxolitinib and has almost near resolution. The other thing that you have to be very careful with this approach is bleeding. Because you do drop the platelets, it's very important to monitor the blood pressure because there's a high risk of posterior reversible encephalopathy syndrome. So very, very tight blood pressure control is very important. And what's important then, what we're understanding is what are the consequences of transplant? So for example, in children that receive a stem cell transplant, the number of visits, length of stay in the hospital, and overall costs improve the year after the stem cell transplant. Adults where we know there's more morbidity and a high risk of mortality, again, there's an improvement in healthcare utilization. Here at the NIH, they showed an improvement in the number of hospitalizations. And here was our data at UIC, where we saw that the inpatient hospital days does go up that first year, and we count those days during the transplant. So 30 days in the hospital is included here. Then by the second year post-transplant, those patients have no hospitalizations, and the cost improves by about $40,000 per year. And so that after 4 or 5 years, the cost saving has already paid off for the transplant. How about the patient's perspective and quality of life? This is really important to our patients. So physical function in children improves, as does pain interference. In adults, again, where we worry that there might be irreversible damage, well, both general health and bodily pain improve using this reduced intensity approach. Then with our non-myeloablative approach, day 30, when the patient is going home, they're already starting to feel better in terms of general health and pain, and it continues to improve 1 year out. Other organ complications that we listed for morbidity and mortality, like stroke risk. So in a very nice study by Dr. Bernardine, who looked at high transcranial Doppler velocities, half were transplanted, half continued on transfusions. And what she showed was that the transcranial Doppler velocity significantly improved after transplant. Well, it remained in a safe zone, less than 200. It didn't show a improvement in the vasculopathy. Furthermore, this comes at the risk of iron overload. And the only person that had a stroke was still on that standard of care transfusion arm. When you look at people that have already had a stroke, there's a very high risk of recurrence. MRI findings have shown improvements in white matter and structural changes. When you look at pre-transplant versus post-transplant stroke risk, both in children and in adults, that recurrence risk drops substantially. Cardiac function is also important. And here in children, we see that cardiac function is stabilized. Here's the pulmonary artery pressure, a marker of pulmonary hypertension, and then diastolic dysfunction markers are stable. In adults, we see an improvement in these biomarkers. And you can see 3 months, 6 months, and 1 year post-transplant, all of those biomarkers improve, consistent with cardiac remodeling and some resolution of the cardiomyopathy. Pulmonary function is also important. A reduced FEV1 predicts early mortality. There's always a concern that the regimen itself and the radiation may have some toxicity, but there's no signal of that in children. And in our adults, those that have very low FEV1s actually improve 1 to 2 years post-transplant. So consistent with improved or at least stabilized pulmonary function. So with talking about curative therapy, we can't do that without talking about gene therapy, because this is really on the horizon and it might become available in the near future. Here, that involves taking out somebody's stem cells, mobilizing it peripherally. The preferred agent is plerixafor because Neupogen or GCSF can trigger a vaso-occlusive crisis. And so plerixafor is used to mobilize the stem cells, modified ex vivo, either with a lentivirus or more recently with CRISPR-Cas9. The patients receive a myeloablative chemotherapy regimen to eradicate the rest of their endogenous stem cells, and then the modified stem cells are reintroduced. And with that approach, the published literature, it's scant, but there's a lot of literature being submitted and presented at abstracts, hopefully at the American Society of Hematology this year. But with the CRISPR-Cas9 lentivirus approach, published data has targeted BCL11A. That's that transcription factor for fetal hemoglobin. They use a myeloablative busulfan PK adjusted regimen. They do see some side effects from that myeloablation, as expected, things like infection. The results have been very encouraging. So here is the approach with the CRISPR-Cas9 showing that fetal hemoglobin was very high, over 40%, while the sickle hemoglobin goes down, almost converting this patient to something like sickle cell trait. With the lentivirus approach, the fetal hemoglobin varies a little bit more, between about 20 and 40%. But both of them show improvement clinically. So in this one patient that was published, after the introduction of the modified stem cells, there were no more vaso-occlusive crises. And in this panel of patients with the lentivirus, there was just a rare episode of vaso-occlusive crisis and a significant improvement in transfusional burden. So we're still kind of following these patients to see if there's any signal of stem cell damage, if there's any off-target effects, but very encouraging thus far. So in summary for part 2, we have therapies that can improve vaso-occlusive crises like hydroxyurea, L-glutamine, and crizanlizumab. And then for the hemolytic phenotype, voxelotor may be an option. And then curative approaches, things like allogeneic stem cell transplant and gene therapy are becoming more and more available. Non-myeloablative approaches seem to be better tolerated in adults. the haploidentical approach increases the donor pool, and we're getting better and better with the regimens and safety and efficacy of that. And the transplants improve healthcare utilizations, costs, and quality of life, as well as stabilizing or improving several different important organ systems. With gene therapy, there are some challenges that are still being tweaked, such as the CD34 dose required, transfection efficiency, trying to de-escalate the myeloablative regimen to a less intensive regimen, and then costs are always an issue. So with that, I would like to thank our patients who are our heart and soul of our program. Many of these patients, all of these patients have been transplanted. I'd like to also acknowledge our blood and marrow transplant team, the nursing staff, both in our clinic on 8 West and in our bone marrow transplant unit, and then our sickle cell center led by Dr. Victor Gorduc. Thank you. I think you're on mute.
All right. So thank you very much, Dr. Santosh. And I think it was a very, very great presentation, which have really educated all of us listening to you. And there are many people listening. And you have summarized in really very short what is it today, what are we having, and where are we. So I am confident this knowledge will help all of us. So if anybody has any quick question, please. Anybody from my panel?
Hello. Yeah, can you hear me? Hello.
Yes.
Yeah, it was a great presentation, sir. I just had a few doubts. One was regarding the dosage of hydroxyurea, because that is something which we have been facing in Chhattisgarh as well. So what is happening is, if you fix a dose, it becomes better, because you can't keep at least the initial dose, because the initial dose is the problem. So right now there's a study already done in our institute. So in that, we found a mean starting dose for the pediatric patients. But even then, if we if there is so we are trying to prepare a dosage chart to hang in hospitals. If we start from 15, then what to give at 25 kgs, 30 kgs, and like that. But I think that starting dosage should be fixed, at least for everywhere. So that is something I don't know. So that has been a problem, I think, everywhere. So that is why I wanted to ask. And I recently what we have found out is at least if we start from 15 to 20, I think it works better, because patients also don't want to come if the medicine doesn't work again and again. If the first month it wouldn't work, the patient would not come back to you. So that is another issue. So if you could just what to
Yeah, that's an excellent question, and I start also at 15 milligrams per kg. So I do that dose, and that usually comes out to 1,000 milligrams, and then I do titrate up one more time to 1,500 milligrams if the patient is tolerating it and still having problems. I don't see much benefit clinically in adults once I go higher than that dose. Once I go more than probably 20 milligrams per kilogram. I do monitor renal function because it's renally clear. So that'll be the only time that I might start at a lower dose of 10 milligrams. So if they have some signs of a reduced GFR or renal insufficiency, then I might start a little bit lower. But I agree with you. 15 milligrams is my starting dose also.
Okay. Thank you. So if I would need some studies also, most people, what they are starting on, basically the first dosage, because we really want to start that in Chhattisgarh, because we've been there is an NGO here which has been working in sickle cell, and our government and institute and AIMS, and together we have sat down a lot of times on this issue. So we want to fix the dose, at least the starting dose, and then just I can share with you the dosage chart which we have prepared, for till supposedly 75, 80 kgs per person as well. So I'll share that with you as well in some time, if it's okay with you, and then we can just go forth with this discussion.
Yeah,
thanks.
I would love
Thanks
to look at it.
Yeah.
Thank you very much, Smita, for this great question. I will tell you that Dr. Jaina and his team and the Odisha team has really worked very hard on defining dosages, and they have really done a great job on the doses. And they have a presentation on low dose, mild dose, and whatever our experience is. If Dr. Jaina is there, I would like him to interrupt here. Dr. Rajesh, is Jaina there? Nirav? Nirav, is Jaina there?
No, sir, he just left, I think,
Okay,
minutes back.
okay, okay, okay.
If you
So,
want, sir, we can call him and just.
yeah, just call him
Yes,
because
yes,
we would like
yes,
to definitely.
yes,
He
sir,
has
yes,
done a
sir,
great job on this.
yes, sir.
And in the meantime, going next, I would really like Asmita just to brief on what are your plans in near future and what do you think is the challenge all of us are meeting in sickle cell.
So, so right now, what we are doing in Chhattisgarh is, I think we have moved very forward. Like before, I think, like since 2018, slowly. So now, what we are doing is we are screening everyone, at least slowly starting to. So at least for the next 3 years, we would be trying to screen everyone from the ages 0 to 40, as per GOI guidelines and as per our state guidelines as well. So we have a lot of HPLC machines. We have a lot of electrophoresis machines. We have solubility tests and POC tests in place in our state. So that is what we are trying to do, because for us to actually, like tackle the disease, we at least need to find the patients first. And unless and until we find the patients, it's not going to work. So that is our first criteria. So if we find the patients, we are trying to, that is what I'm saying. So the next thing which we found right now was the problem of administration of hydroxyurea by a lot of doctors. That is why I was asking, like what we are doing is, that is why we are making a dosage chart. So right now, so after we, like we found the patient, so we are trying to administer hydroxyurea. We are also actually trying to get pneumococcal vaccinations for our patients as well. So slowly, of course, like we will try to put counselors in place as well, and obviously like get probably a good design for the program. Hello, can uh, can you hear me?
Yes, we can.
Yeah. So that is what we are planning, at least for our state. So since Chhattisgarh has been, like it is very endemic for sickle cell anemia, especially in the middle belt and in a tribal belt in Bijapur. So that is what we're trying, and let's hope slowly. So this year also we have planned at least to screen, at least 60 lakhs people. So let's see. The planning is still going on. So that is how, and we also have like we have good units in place. We have proper sickle cell units in our like in our district headquarters. So the in the units, basically what they do is they screen the patients also, but then they also follow up the patients. So right now, what we have a portal also. So we try to look at the number of follow-ups a patient has. If we are losing a patient, because that is also another concern. If we are losing a patient, that means that, like, with obviously the program didn't work well. So finding a patient is one thing, then getting the medication for the patient is another thing. And if we can actually continue that medication when the patient is following up and coming to us for medicines. If the patient doesn't come, because in especially in Chhattisgarh at least, we have a lot of patients who are very poor and they do not want to come to you again and again if the medicine doesn't work. At least if in the first 2 months it should show them results. So if it does show them results, then they will obviously come to you. So what we are seeing right now is, in a lot of places, the blood transfusion has come down to less than 5%, less than 1% in a few cases. So it has been amazing to see that. But we are still lagging because we have not identified all the patients. So let's see. Yeah. That's all I can say, like, for Chhattisgarh.
Thank you very much, Asmita. Now I would request Mr. Gautam to say a few words and the challenges you are facing in the society.
Thank you so much, sir. As Dr. Smita already mentioned, that the hydroxyurea, this is the main challenge of our society, because in my experience, my two kids are suffering from sickle cell disease, and one is 18 age and the second is 13. So last 15 days before, they were taking a minimum dose of 10 mg per kg per body weight. Since and that's why they were always facing pain crisis frequently in 1.5 month, 2 month. But when I got to know about the doses that we can raise up to 15, 20, 25, 35 milligram after having the international meeting, then I said to my doctor that why not we should increase the dose. Then they advised and increased the dose last 3 years before. So 20 mg per kg per body weight they given started, and since last 3 years they have no pain crisis. Yeah, both my kids are very good. They are performing well. They are participating each and every field. They are enjoying their life due to only the change of the dose of hydroxyurea. And hydroxyurea is very economic drug and easily available. Government is supply free supply. So the need is that we need to aware our professional doctors, you know, that what is the protocol of hydroxyurea to prescribe. And second, we need to aware the patient also. Those who are not getting, they should also know that this medicine is for that patient. So the patient can also suggest to the doctor, please prescribe me. So that ultimate aim is that sickle cell patient should get hydroxyurea in proper dose. So 93% patient are uh, giving response in India on hydroxyurea. As one research published by something in webinar, doctor was saying that only 7% patient are not responding. They may be the for transplant. So my suggestion is that for my community, as I am the sickle cell patient voice, so I am raising this issue that please make available hydroxyurea in each and every PSC and district hospitals. Also, the doctor can write the hydroxyurea in PSC level and district hospital level. Also, second thing, the quality of hydroxyurea capsule. You know, I will not say the name, but yes, I saw the quality of hydroxyurea is very poor in government sector, because there is a trend of tender based. Those who are uh, those who are giving the minimum rate to the government, then government purchase from those company, taking a least amount from hydroxyurea. So my opinion that please purchase good quality hydroxyurea. It is not so costly, not so costly. You know, at least many companies, many branded companies having generic. You know, I am purchasing 3 rupees 20 paisa per capsule in good quality of generic capsule. Only 3 rupees 20 paisa per capsule, which is more standard than what government is supplying to our patient. Because I saw the strip when I break the capsule, because we have to break the capsule because of the doses. Only 500 mg capsule is available. So when we break the capsule, the all powder melted. So this uh, how the patient will get benefit after getting this type of medicine quality. So the in last thing that we want to the save the life of the patient, hydroxyurea in the doorstep with quality and with the proper protocol by the doctor. These things, if we will get, then obviously 93% of patient can live a good life. Thank you so much.
Dr. Gautam, I wanted to actually ask a question to Dr. Garima, but Dr. Jaina is there. So Dr. Jaina is head of the Indian Society of Hematology. They have just released a new guidelines on sickle cell disease along with ICMR. And I know he has been trying through his society and his personal efforts to resolve this issue of hydroxyurea and dosing of hydroxyurea. So, and we know basically Dr. Jaina is a basic researcher on sickle cell disease with large number of patient population, clinical work, as well as a lot of experimental work. So I would request Dr. Jaina to just put his say his few words on the issues related to sickle cell.
Okay, thank you, Dr. Dinesh. It's a very good point which has raised by Dr. Gautam. There are three prospective studies in India. Both they have included both pediatric and adult population. One was from my institute, and second was from Burla from Odisha. Then third was from Nagpur by Deepti Jain. They have utilized both pediatric and adult patients. We have given a low fixed dose at 10 milligram per kg per day. And what you are found, these all the three prospective randomized studies were unanimous in proving that its effectiveness is more than 90% cases, as you have rightly told, say 93 to 95% of cases. So with this based on these three evidences of the three randomized prospective trials, for the Arab Indian hepatitis patients, we strongly recommended hydroxyurea to be initiated at the dose of 10 milligram per kg per day. However, in certain patients, if you do not achieve the maximum or the optimum effect, still the vasopressin crisis or the symptomology is still present, you can gradually increase, keeping your absolute neutrophil count and platelet count, keeping in view also. But in most of the cases, you will be able to manage at low fixed dose. The advantage of this low fixed dose is that not only cheap, and it will really save a lot of cost. And if you look at the cytopenia, hydroxyurea is supposed or expected that it causes cytopenia, and it has to be titrated, monitored regularly, etc. There is a fear complex that it cannot be prescribed at the primary health center or community level or tribal populations. But I can guarantee you that we have used extensive use for more than 30 years, starting from 1 year child to 8-month child to even adult and geriatric population also. It's a fantastic drug, very safe, effective, and the incidence of cytopenia is extremely uncommon, maybe 1 in some thousand, to the extent even you can forget. So that is really at a community level. So low fixed dose is very, very effective, safe, and you need not monitor. We have noticed in some cases that maybe cytopenia is a mild to moderate, which is a very reversible. Once you stop the hydroxyurea, it automatically reverses. So our recommendation is that 10 milligram per kg per day in more than 90% cases will be okay. And in few cases, you can increase depending on what you can go up to maximum tolerated dose. And Dr. Gautam, again, one thing point that every detail has been mentioned in that guideline, which I can share with you, or Dr. Dinesh can share with you. Every details, how the Indian patients, every component of the sickle cell disease has been described, which is relevant to the Indian settings concern. And second point is, as you all told, it's only hydroxyurea capsule is available so far India is concerned. There is no tablet or there is no liquid form. Again, you will surprise that we have done it. You break the capsule, tell the mother that on a gross examination, you can divide the powder, that 500 ml powder, 500 milligram powder into 2 doses, 3 doses, 4 doses. Though it's not scientific, though it is not rational, but it works, it effective. In absence of any other alternative, if you divide the capsule and give the powder in a gross calculation form, it is still effective. And we are doing it also till the tablet and the syrup formulation is available. Myself, Dr. Dinesh Pandrakar are working hard in negotiating with the Drug Control of India how that hydroxyurea tablet and syrup are available. Every detail has been mentioned in that guideline. You can refer to that. And I would like to answer any further queries or questions so far as sickle cell is concerned. It's over to Dr. Dinesh again.
Thank you very much, Dr. Jaina. Now with us, we have Dr. Garima. She is a pediatric hemato-oncologist, extensively working also in the field of sickle cell. She has really a great experience of clinically examining and writing multiple papers in recent past. So I would request her to really say a few words. She is especially actually interested in bone marrow transplant of the sickle patients, doing multiple transplants. So I would like to hear her views on the issues we are discussing here. Garima, please.
Thank you so much, Dr. Pandakar, sir, for giving me this opportunity. And thanks a lot, Dr. Saraf, for very informative session. So I mainly deal with the transplant aspect of sickle cell disease patients. What I feel is that like we should educate the physicians and the parents for keeping transplant as one of their options. We should tell them, and definitely we should screen. Like in India, we have a lot of siblings, so we should screen the siblings for HL for matched sibling donor transplant. Like we should at least do an HLA, and we have a lot of NGOs which will help us in getting the in paying for these patients for the transplant. And one more important thing which I want to like emphasize is that the patient, even if the siblings are trait, still they can be ideal donor for the patients with sickle cell disease. So and transplant, as shown by Dr. Saraf, has tremendous outcomes in the especially in the pediatric patients and adult patients. We do it properly. And like uh, in present scenario, not only matched sibling donor, the other alternative donor transplant is also very successful, like half match. So every patient of sickle cell has a half match donor, either father, mother, or a sibling. So that is also a very promising option for patients with sickle cell disease. And regarding like hydroxyurea, everybody has put on their opinions, which is quite informative. So using hydroxyurea is like the key to success. And even in our study, we have shown that there's a tremendous improvement in the symptoms if patients are using hydroxyurea regularly. Like we should advise them not to skip the doses. We should sit with them and we should tell them about the importance of taking hydroxyurea every day and to monitor them for the side effects. Thank you.
So I would like to add one small thing. Me and Dr. Garima, we reviewed few patients in Odisha, especially level of hemoglobin F, who were taking low dose hydroxyurea as advocated by Dr. Jaina. Let me tell you, we compared their hemoglobin F levels on the day of our examination and their day one report of HB electrophoresis. Practically all of them had more than 20% HbF, which is our target of treatment. So I agree with philosophy of Dr. Jaina that probably low dose hemoglobin F. So now I have a document which I can prove that even low dose hemoglobin, low dose hydroxyurea, 10 milligram per kg body weight does work, because HbF levels are really maintained beyond 20% as advocated by majority of the organization. So I personally feel the work being done by in Odisha is a great work. And as Dr. Garima has said, we have to educate people, we have to educate physicians, we have to educate NGOs that as of today in the country, transplant remains the best option. And fortunately, there are a lot of NGOs available to fund the transplant. So money should come next. Desireness of the patient should come first. And I wish that all our NGOs work together. So I will be coming back to Dr. Atul Gera on this issue, because he is an important NGO from Jharkhand. But Dr. Dexter has joined. So I would request Dr. Dexter to really say a few words. Dr. Dexter is doing large number of sickle activities in Gujarat. So we have now attendees, the really big NGOs from Gujarat, Jharkhand, Chhattisgarh, which is the belt of sickle cell in the country. So Dr. Dexter, please, your comment, please.
Thank you very much, sir. I am on the way, so my network is not good, but nice to hear all of you. मैं इतना जरूर कहना चाहूंगा सर कि सिकल सेल के लिए कुछ काम करना है तो पहले तो हमें अवेयरनेस पे काम करना पड़ेगा, क्योंकि जब तक पब्लिक अवेयरनेस नहीं होगी जब तक हम वो जो गोल अचीव करना चाहते हैं वो नहीं कर पाएंगे। बाद में हमें पैरामेडिकल्स को गांव के अंदर जाके डायग्नोस्टिक फैसिलिटी को गांव के अंदर ले जाना पड़ेगा, तब जाके हम अच्छे में अच्छी लोगों तक अगर डायग्नोस्टिक और अवेयरनेस अगर लाएंगे तो हम बहुत से अच्छा गोल हासिल कर सकते हैं। क्योंकि ट्रीटमेंट पार्ट देखेंगे, लेकिन ट्रीटमेंट पार्ट तब काम आएगा कि जब लोगों को पता होगा कि मुझे कुछ बीमारी है या मुझे कुछ है या ट्रेट है या डिसीज है या फिर अदर कोई हीमोग्लोबिनोपैथी है। तो अभी तक हम अब ऑन द वे है। अभी भी आज हमने 400 के 500 एसपीएलसी रिमोट एरिया में जाके आज हमारा कैंप था, तो वहीं से हम आ रहे हैं पूरा सभी फ्रेंड्स। तो सर लोगों को 35 या 40 ईयर्स तक भी मालूम नहीं रहता कि मुझे डिसीज है कि ट्रेड है। हाँ, उनको स्क्रीनिंग करने के बाद सिर्फ सिकलिंग है ऐसे करके भी बहुत से लोग मेडिसिन लेते रहते हैं, फॉलिक एसिड लेते हैं, जो भी कुछ लेते हैं, लेकिन एग्जैक्टली उनके पास एसपीएलसी जो होना चाहिए डायग्नोस्टिक फैसिलिटी वो नहीं होने की वजह से वो लोग अपने आप ही कुछ खाते रहते हैं। तो यानी पैरामेडिकल स्टाफ को भी अभी हमें एजुकेट करना पड़ेगा, तब जाके हम क्योंकि जब तक पैरामेडिकल स्टाफ एजुकेट नहीं होगा तब तक वो डॉक्टर के पास नहीं जा पाएंगे। तो हमारा सबसे बड़ा बिग चैलेंज है रूरल इंडिया। क्योंकि और सिकल सेल की बात करेंगे तो सिकल सेल ज्यादातर रूरल इंडिया के अंदर है और ज्यादातर ट्राइबल बेल्ट के अंदर है। तो वहाँ अभी भी हमें जो फैसिलिटीज मुहैया करानी चाहिए या फिर अवेयरनेस होना चाहिए लोगों में, क्योंकि वो कम्युनिटी बेस पे वहाँ चलता है सर। ऐसा नहीं हर एक जगह उनकी जो भाषा है, उनका जो कल्चर है, उस पर भी हमें ध्यान देना पड़ेगा, तब जाके हम उन तक उनको पेनिट्रेट कर पाएंगे, वो हमारी बात समझ पाएंगे। तो सबसे बड़ी बात चैलेंज है हमारी डायग्नोस्टिक फैसिलिटीज और अवेयरनेस फैसिलिटी। अगर दो अगर अच्छी तरह हो जाए तो बाद में हम सब बहुत सारी चीज हम हासिल कर सकते हैं।
Dr. Dexter, I totally agree with you. Whenever we also went to all these areas, and we went to multiple areas in the country, we realized that patients think they've got sickle cell disease, but they actually do not know whether it's a sickle cell trait or a disease. Unfortunately, routines just sickling test in many places is common, and based on that, we are taking decisions. So I earnestly request all of us, all the players, the NGOs, the doctors, the government, that we should try to focus on confirmatory tests before labeling any patient as sickle patient. And because of that, I think the number of patients will get reduced. We will exactly know who is a sickle patient and probably will be able to help better. So I totally agree with you that we really need a confirmation of sickle disease so that we can actually educate the patient better what are the best options. Atul, can I request you to intervene here?
Yes, good evening, sir, and good evening, everybody. I think I very much agree with Dr. Dexter, and our Jharkhand is again a very tribal dominated place, and we have a lot of sickle cell patients, and the same problem we face, every day about, people are not knowing about their real status, about being traits or a confirmed sickle cell patient if they are. Then I think very importantly, what Gautam ji marked, that the availability of the drugs, and but before that, once even when you are not, diagnosed with the real problem, later on comes the drug part, and unfortunately, we just, recently had a first hematologist here in Jharkhand. So till date, Jharkhand being the most tribal dominated state of the country, the tribal minister coming from Jharkhand, we never had a hematologist in the state. So people were still dependent on going out of the state or getting diagnosed, and then again when they come back, if at all doctors get into that diagnostic things, HPLC is not there in any district. Out of 24, I think only 1 or 2 districts would be there which would be having this confirmatory HPLC, which is only done in the medical college. So it's such a challenge, even if firstly they are not properly diagnosed. If they are diagnosed, then the drug is not available. So after so long time, the Kuti is now having the place where our tribal minister comes from. So we have now the availability of hydroxyurea, and the screenings are going massively. But other than that, the districts, Kuti and probably Ranchi started a little early, and the other districts are still far behind. So it's a great challenge for a state like Jharkhand, where we don't have specialists, we don't have the confirmatory test, at all the districts, and we are heavily tribal dominated place. So it's a big challenge. We keep hearing, and very unfortunately, we still see deaths happening with patients coming somewhere with pain crisis, and somehow they were not given blood on time. Patient was in crisis. So I think the sensitization, awareness, and then education, uh, proper test, then diagnosis, and then again the right doctor, prescribing the right medicine, then availability of medicine, everything is a challenge over here. So I think while hearing so much things, we in Jharkhand are much behind, and a lot of things needs to be done here. So I really hope in coming days, and I'm thankful Dr. Pindarkar is coming to us on 19th World Sickle Cell Day. He would be here in Koti, and daycares are coming up, but again, it's more on papers. So even if there is a hemophilia, which is a daycare, so it has been shown as the daycare setup under hemoglobinity is already there. But hemophilia, I think they have been a very organized group, and just because of the presence of factor, so on papers it seems that the daycare is functioning. But the other two, thalassemia, sickle, and thalassemia is little more sensitive because they keep requiring blood, so they are always on news and somehow they take some attention. But I think sickle cell completely lose attention also. So they are nowhere in discussion also. Most of the times they are nowhere into news also, I think, which is so important to somehow the advocacy for them, or in a bit larger way, people talking about sickle is much less than other diseases. So I think in Jharkhand there is lot to do for them, and I think what we need is actually we need to strengthen the more basic, rather than I'm not even I can even afford to talk about BMTs right now. I mean, there are patients who have been going out. In fact, most of them go out at least once, but there is a very big lot who cannot even afford to move out. So I think this place really require a lot of things at the same time, and in right proportion, right place. So I hope someday, things starts happening. But yes, at least we have a hematologist in Ranchi, in the capital city. So things have started moving, but lot to do.
Thank you very much, Atul. And you are doing a great job by moving people, moving donors, and bringing blood to the blood bank. And that is one of the major requirements in the country for thal and sickle. So I am very happy that you are really moving. You are advocating the voice. Gautam is doing great job by really moving. Dexter is really doing. So all of us, all of you are really working at a society level to make people aware. So before we go to the next time, I would really again request any one of you who would like to say a word or add something or more comments. Please, I would start from Dr. Jaina. Sir, more comment, if any.
Yes, sir. Good evening. I think, as you know, the sickle cell disease has many peculiarities. One of the peculiarities that, unlike other medical diseases, there are different haplotypes with different phenotypes and morbidity mortality pattern across the globe. We have Senegal, Benin, Bantu, which is more often African haplotype, vis-a-vis with the Arab Indian haplotype. So whatever we are saying, or whatever the recommendations are coming from West or African countries, is not true in most of the cases in our patients group. This is number one. Number 2 point is that another peculiarity is that it has a huge social stigma. As somebody was telling, Atul was telling, unlike other thalassemia major, the sickle cell carries a huge social stigma. So whatever the benefits are coming, unless it has to reach to the poorest of the poor or the every part of the country. And third is, there is a huge inequity in the healthcare services among the sickle cell disease. If you compare diabetes or hypertension or other diseases, there is a more or less comparative healthcare services available across the globe, across the country, or across in India. But if you look at the healthcare facilities available or whatever being benefited by the patients across the country, there is a huge difference. Probably the greatest inequity of the healthcare services happens in sickle cell disease. And my last point is that unless and until you raise the healthcare services or the healthcare facilities to a great extent, unless and until a sickler feels confident that I can lead a normal life, I can lead a healthy life or up to a normal life, I can marry, I can have a children, I can take the advantage of the technical advances like prenatal diagnosis, or I can choose my baby, I can go for transplantation, etc. Unless and until we raise the bar of the healthcare services to a normal life expectancy of sickle cell disease, no matter what is the awareness program which are going to create, it won't be effective. It is a failure across the globe. So that's my point. Along with the screening awareness program, a holistic healthcare services has to be developed across the country. Then only we can break that, we can destigmatize the sickle cell in our country, so that all the benefits which are available will reach or will be available by the patients. These are my few points which I want to highlight on this important and very important day of the World Sickle Cell Disease. Thank you, Dr. Dinesh. Yes, over to Dr. Dinesh.
Thank you. Yes, Dr. Gautam. Mr. Gautam, please.
हाँ सर, मैं भी इसमें ऐड करना चाहूँगा 2 चीज़ें कि जो अतुल जी ने कहा, डॉक्टर डेक्स्टर सर ने कहा और जीना सर ने कहा कि वो बहुत ही इम्पोर्टेंट है कि हमें जानना कि सिकल सेल पेशेंट है क्या? अगर वो जानेंगे तो हम उसको आगे का उसका ट्रीटमेंट पार्ट हम लोग ठीक कर सकेंगे। तो मैं समझता हूँ इस इम्पोर्टेंट फोरम में कि अ, अगर पेशेंट जो ट्राइबल का है, वो जाता है प्राइमरी हेल्थ सेंटर में पहले या फिर डिस्ट्रिक्ट हॉस्पिटल में। तो क्या डिस्ट्रिक्ट हॉस्पिटल या प्राइमरी हेल्थ सेंटर के डॉक्टर्स हैं, जैसे डेक्स्टर सर ने कहा पैरामेडिकल, और मैं बोलूँगा कि डॉक्टर जो मेडिकल ऑफिसर है, उनका एक बार सिकल सेल ट्रीटमेंट का ट्रेनिंग वो कंपल्सरी हो जाए। क्योंकि बहुत सारी जगह पर हम लोग नेशनल अलायंस है, हमारे साथ 17 स्टेट्स के पेशेंट जुड़े हुए हैं। तो जब वो बताते हैं कि उनको तो कभी हाइड्रोक्सी यूरिया लिखकर ही नहीं दिया गया है, उनको सोडामिंट रेगुलर दिया जाता है, फॉलिक एसिड दिया जाता है। 30-30, 40-40 वर्षों तक वो सोडामिंट और फॉलिक एसिड पर है। जबकि हमें पता है कि डॉक्टर्स कहते हैं सोडामिंट का ज़्यादा यूज़ नहीं है, फॉलिक एसिड सपोर्टिव है, बट हाइड्रोक्सी यूरिया थोड़ा एक प्रिवेंटेबल मेडिसिन है। तो मेरा इस फोरम में रिक्वेस्ट यह रहेगा कि जितनी जल्दी हम प्रोफेशनल्स को ट्रेन कर दें, उतने जल्दी पेशेंट डायग्नोस होना शुरू हो जाएँगे। पेशेंट इसलिए डायग्नोस नहीं हो रहे क्योंकि प्रोफेशनल ट्रेन नहीं है। एटलीस्ट जो डिस्ट्रिक्ट्स, जो स्टेट सिकल से प्रेवलेंस है, छत्तीसगढ़, मध्य प्रदेश, झारखंड, महाराष्ट्र, ये ऐसे स्टेट्स के सारे डॉक्टर्स लोगों का प्रॉपर ट्रेनिंग हो करके एक बार सारे पेशेंट्स का के जो सिम्टम्स है, कॉमन सिम्टम्स है, जैसे एनीमिक हो जाना या फिर जॉइंडिस होना या फिर फ्रीक्वेंटली बॉडी पेन होना। फ्रीक्वेंटली बॉडी पेन की वजह से लोग डॉक्टर्स अर्थराइटिस की दवा देते हैं। जॉइंडिस जैसा दिख रहा है तो उसे जॉइंडिस की मेडिसिन दे देंगे, मोस्टली आयुर्वेदिक या फिर झाड़-फूँक, इस तरह का इस बेल्ट में ज़्यादा है। मोर देन 60-70% लोग तो आयुर्वेदिक और झाड़-फूँक इस तरह की चीज़ों में अपना समय वेस्ट कर रहे हैं और ज़िंदगी को भी गँवा रहे हैं। तो हम चाहते हैं कि जितनी जल्दी अवेयरनेस प्रोग्राम गवर्नमेंट के थ्रू हो या जितना हम लोग एनजीओस के थ्रू कर रहे हैं, हम लोग यूट्यूब चैनल और अपने वेबिनार्स के माध्यम से जितना हो सकता है कर रहे हैं, लेकिन हम पूरे नहीं पड़ेंगे क्योंकि ये देश बहुत बड़ा है, 17 स्टेट्स हैं। हम चाहेंगे गवर्नमेंट इन्वॉल्व हो, जो कि अभी 27 तारीख को माननीय प्रधानमंत्री जी के हाथों से अब सिकल सेल मिशन शुरू होने वाला है। तो उसमें अवेयरनेस का बहुत बड़ा पार्ट हो। जिस तरह से पोलियो का, ट्यूबरक्लोसिस का, एचआईवी का जो अवेयरनेस और एक यूनिट बना करके उसका सेपरेट डिवीजन दिया गया है, वैसे ही सिकल सेल का भी एक यूनिट बना के सेपरेट मिशन दे करके उसमें किसी और बीमारी को ऐड ना करके, जनरली मैं बोलना चाहूँगा कि किसी भी और ग्रुप को ऐड ना करके स्पेशली सिकल सेल पर ही फ़ोकस करें, तो ये पेशेंट्स हम बहुत जल्दी कैच अप करेंगे। आज भी 35-40 ईयर, 50 ईयर में डायग्नोस हो रहे हैं। जब आज डायग्नोस हो रहे हैं, तो कब उनका ट्रीटमेंट प्रोटोकॉल होगा? तो इसी तरह न्यूबॉर्न स्क्रीनिंग भी कंपल्सरी कर दिया जाए सारे स्टेट्स में। सभी प्रेग्नेंट वुमन का टेस्ट कंपल्सरी कर दिया जाए। प्रीनेटल टेस्ट की सुविधा हो जाए, ताकि हम होने वाले सिकल सेल बच्चे को रोक सके, और अगर जो गलती से आ गया है तो उसको सही समय में इम्यूनाइजेशन दे करके, प्रॉपर ट्रीटमेंट प्रोटोकॉल दे करके, निमोकोकल वैक्सीन जो कि छूट गया हो अडल्ट में भी दे करके, ऐसे पेशेंट्स की हम जिंदगी बचा सके। कुल मिला के ये जो आज का हमारा वेबिनार है, उसका उद्देश्य तो पेशेंट की लाइफ को बचाना है। तो पेशेंट की लाइफ को बचाने के ये मुख्य एस्पेक्ट्स है कि उनका डायग्नोस हो जाना, उनको उनके डोर स्टेप पर मेडिसिन मिल जाना, क्वालिटी मेडिसिन मिल जाना, और उनका लाइफ सेव होना। इन इन सब चीज़ों के लिए बहुत ज़्यादा फाइनेंस नहीं लग रहा है, बहुत ज़्यादा देश का पैसा खर्च नहीं हो रहा है। देश का पैसा खर्च हो रहा है वो जब एडमिट होते हैं फ्रिक्वेंटली 5 दिन 10 दिन 15 दिन 20 दिन में 1 महीने में एडमिट होते हैं तो उसके पीछे जो 7 दिन का हॉस्पिटलाइजेशन का खर्चा है वो कई गुना ज्यादा है। 14 लाख पेशेंट मल्टीप्लाई बाय हॉस्पिटलाइजेशन अगर आप खर्च देखेंगे तो वो एक कई अरबों खरबों रुपए में जाएगा। जबकि हम अवेयरनेस और स्क्रीनिंग करके उनको डायग्नोस करके उनको प्रोटोकॉल में देंगे तो वो बहुत मिनिमम खर्चा होगा। इससे हम 2 चीज़ कर सकते हैं सर, इससे हम देश की आर्थिक स्थिति को भी सुदृढ़ कर सकते हैं। देश में सिकल सेल की वजह से अपंग होने वाले दिव्यांगों की जनसंख्या को कम कर सकते हैं, ताकि वो भी देश की सेवा में अपना हाथ-भार लगा सके। क्योंकि मेरे घर में 2 सिकल सेल पेशेंट हैं, मुझे पता है कि जिस घर में सिकल सेल पेशेंट होता है, वो या तो घर में होता है या हॉस्पिटल में होता है। तो वो देश सेवा में बिल्कुल सपोर्ट नहीं कर पाता। तो ये सारी चीज़ों को हम मिनिमाइज़ कर सकते हैं और सेकंड जो ऑलरेडी सिकल के साथ जी रहे हैं, उनकी हम क्वालिटी लाइफ़ में चेंज कर सकते हैं, ये छोटे-छोटे चेंजेस करके। तो आज के माध्यम से अगर ये चीज़ें हो जाए तो बहुत इस मैसेज को अगर सरकार तक पहुँचाया जाए तो बहुत अच्छा होगा। थैंक यू सो मच।
Thank you very much. Asmita, anything you would like to add? Garima, would you like to add anything? Okay, so if nobody would like to add anything, I would like to add that today's activity had been designed just to increase awareness amongst ourselves at what we are supposed to do, where we are heading for, and how can we bring everything on the track. So my philosophy of training had been very clear. You will never be able to train all the physicians and all the health workers and paramedics. It is impossible. It is not doable. We have not been able to do for last 70 years. You will never be able to do it. Please remove the target of educating everybody. Let us select a group of people who should be educated. They should be given the task of taking care of sickle patients, and we will be able to then offer better care. Because if you want to train every Asha worker, every Anganwadi worker, or every doctor to take care of sickle, this is not going to happen. We have been able to do this in cancer, and believe it, cancer care has been come on a it's on a good track in 8 states of India. Similar experiment can be done with sickle. That's what we are trying. I'm already in negotiation with the government of Odisha. Myself and Dr. Yena are working on it. I am already talking to government of Chhattisgarh also to bring it on a track. So we don't want to train everybody. We don't want to be everybody expert, but we want to train at least somebody available all the time where a patient can approach and get 24/7 backup. So I think this is doable. Now at the end, I would request our chief guest today, Dr. Santosh, to say a few words and advise us what he feels about the problem. I can only tell you that compared to if Africa, we say, is number one in sickle cell, it is Africa, sub-Saharan together. It is not one Africa. Here we are talking of India, which is one India. Believe it, our problem is much bigger than African problem. Their number is bigger because there are too many countries together. Here it's one country. If we really take in the population in relation to India, we have a much bigger problem to fight. We have to take the disease very seriously, which we are already taking. Government is focused, government is interested, and I'm sure we together will be able to resolve this issue. Dr. Santosh, please.
Yeah, I think it's very interesting to see the perspectives, and we have a lot of the same problems. We have problems with access to medications. Patients don't come back sometimes, and they want to see those immediate results 2-3 months, or else they'll stop taking the medicines. I think the dosing is a very valid question. So I think strategies where you have the low dose, if they don't benefit, then trying the titration is a reasonable approach. Understanding the genetics of what drives some of the complications will be important. And this might help us guide who needs more aggressive therapies and perhaps who should be evaluated for transplant before their disease gets too complicated. But I think that I'm very excited to hear all the different things going on and to hopefully be a part of collaborating with everyone.
So thank you very much. I would like to close the session here, but I would still like to say a word to all of you. If anybody still would like to have a comment, you are welcome. If no comments, then we would like to. Asmita, you want to say something?
I just wanted to say that in Chhattisgarh, so recently for the last 6 months, it has been very hectic and we've done a lot because we've been training and training and training doctors in district hospitals and CHCs. And obviously we have achieved like beautiful results because I myself, I analyze the data every Monday. I look at it like if they're actually, if these many sickle cell patients are there, so are we actually giving them medicines? Are we actually following them up? So again, I would like to reiterate because the problem has arisen from AIMS, from Institute, and again from a very small NGO in Ambikapur. And we have found out these problems that it is difficult to actually follow up the patient. The finding a patient is one task. Second is actually like getting the patient on treatment, and third is following up of the patient. It is difficult to follow up the patient. The patient might not come back to you if the dosing is not proper. That is what we have. That is what we are getting from the what we are doing. So right now, we are actually, we have been doing a lot of meetings again for the dosage chart, and also exactly, how do we actually screen the population. And we want to do the again I want to tell you that we are actually doing CVS test, which is prenatal test, from at least our insurance schemes. We do not have it in our government hospitals, but we are doing it for a few patients who actually ask us, so we try to give it to them from Ayushman Bharat scheme. So that is also happening. And for the pneumococcal vaccinations also, we are in talks with Government of India to give it to them for free. So we're trying from every end possible. That is all I can say. But let's see. Yeah.
Asmita, let me tell you
Yeah.
two great things about you.
Yeah.
So I'm going to Jashpur on Tuesday. There are 160 patients registered in Jashpur. There is one doctor who is following all of them. He has all details of them, and all of them are proper hydroxyurea. This is one doctor which I trained when I was in Raipur. I did training of 35 doctors, one from each district. He is one of them. So it's a great news for you. I spoke to my doctor in charge in Raigad today in the afternoon, and I said, what is the status of sickle cell? After 2 hours, today in my phone, today, I'm talking today, I have a list of all the SS and AS registered with their mobile numbers.
Of course.
So that's a great thing. You have really achieved a lot. It's very good. I'm sure with this speed, you will do a great thing. So thank you very much. Thank you all of you for participating. And I would really request Rajesh Sharma, who is our main force behind this organization, to say the last word. Rajesh, please.
Thank you, sir. I am grateful to sir and his dynamic leadership. We have been organizing every year this educational and meeting of sickle cell force working together, and under his leadership, I will start from where Gautamji has left. Gautamji has said in his words that our mission should be last mile delivery, and Dr. Pinarkar's mission and National Cancer Society mission is also the last mile care delivery that way. And Atulji or Asmitaji or Dr. Dexter, everybody, Dr. Jaina, in their respective states are leading that last mile delivery, and a lot can be done. And I'm grateful to Dr. Santosh Sharaf. On a very short notice, quickly has accepted the invitation, and we could give final shape to this. And not the most important, our attendees. We have about 200 plus attendees who have watched live this program, and countless number of people on LinkedIn, Facebook, and YouTube. I don't have count of them, but I'm grateful to all of them. Thank you so much.
Thank you.
Thank you so much. Thank you so much.